everyone. Welcome to series Identifying and Treating Connective Tissue Disease, Pulmonary Arterial Hypertension, also known as CTD-PAH, impacting an at-risk patient population. The first webinar or series topic is the burden of CTD-PAH patient perspective. I am Dinesh Khanna. I'm a rheumatologist and director of the scleroderma program at the University of Michigan in Ann Arbor, Michigan, United States. Here are my appropriate disclosures. The program has been supported by North American Center for Continuing Medical Education and HMP Global Company, and the program has been supported by an educational grant from Actelion Pharmaceuticals and Rheumatology Consultant. And here are the learning objectives for the first seminar out here. Summarize the multifaceted impact that CTD-PAH has on patient morbidity and mortality. Before we start, I want to hear from a patient. This is a very nice video that has been recorded by a patient who has both pulmonary arterial hypertension and systemic sclerosis, highlighting the impact of this disease on day-to-day activity, emotional, social, and mental well-being. Let's listen to her.
Hi, my name is Leah, and I'm 58 years old. I developed systemic sclerosis, also known as scleroderma, 6 years ago. My symptoms started with pain and swelling of my hands and fingers, and I had a Raynaud's phenomenon where my fingers were turning white and blue. I have been depressed with the diagnosis of scleroderma, but I am now used to living with chronic pain and Raynaud's phenomenon. Scleroderma can be associated with pulmonary hypertension or PAH, and I was diagnosed with PAH last year. Since my diagnosis of PAH, I have lived with fear and uncertainty due to the high risk of death and disability. I continue to have constant fatigue, and erraticness of the fatigue is hard to plan for. It arrives very unexpectedly. I often get shortness of breath when I walk the stairs at my home, swelling in my legs and feet, and recurrent chest pain. I schedule my life around my shortness of breath that can bring my daily activities to a screeching halt. If I keep to my own slow pace, I can walk a good distance without really feeling shortness of breath. But it happens almost immediately with tying my shoes, loading and unloading the dishwasher, and doing laundry. Anytime I have to bend, I feel shortness of breath instantaneously. I am on PAH medications and a water pill. I get dizziness, swelling of my body, but I can't separate the side effects of medication versus the worsening of PAH. I live in constant worry about worsening of the disease, and I'm very scared to read about PAH on the Google search engine and other search sites.
So now let's dive into what is pulmonary hypertension. As I highlight on the slide, pulmonary hypertension is a hemodynamic observation that's associated with elevated pulmonary pressures that has multiple etiologies. Once you make a diagnosis of pulmonary hypertension, that should lead to identifying an underlying cause. Most of our discussion today will focus on pulmonary arterial hypertension, which results from restricted flow through the pulmonary arterial circulation, causing increase in pulmonary vascular resistance and ultimately right-sided heart failure. There are multiple connective tissue diseases. I'm a rheumatologist. Why are we talking about pulmonary arterial hypertension? Because rheumatologists do diagnose, screen, and sometimes treat pulmonary arterial hypertension. We focus on systemic sclerosis because that is the most common CTD associated with pulmonary arterial hypertension. Approximately 75% of cases that are out there associated with CTDs, PAH, are due to scleroderma relationship. Scleroderma PAH has worse prognosis than other CTD-PAH patients, and pulmonary arterial hypertension, unfortunately, is one of the leading causes of death in our patients with scleroderma. But I also want to highlight for you the other CTDs that may be associated with pulmonary arterial hypertension. What are those? Mixed connective tissue disease, lupus or systemic lupus erythematosus, rheumatoid arthritis, dermatomyositis, undifferentiated connective tissue disease. I'm not asking my colleagues to start screening every patient on an annual basis with echocardiogram or other tests. What I'm asking is to keep that in differential diagnosis when you think about other diseases other than scleroderma or systemic sclerosis. Finally, the Sixth World Symposium on Pulmonary Hypertension concluded in 2018 that screening should be done in every patient on an annual basis that has systemic sclerosis or scleroderma spectrum disorders. Now let's do a deep dive into the relationship and the prevalence of CTD-associated pulmonary arterial hypertension. I'm showing you the data from Reveal Registry. It's a United States-based observational cohort in patients who had pulmonary arterial hypertension on right heart catheterization. I want to emphasize, and I will emphasize in different series, that right heart catheterization is the gold standard to diagnose pulmonary arterial hypertension. On the left side of the slide, I'm showing you the overall population of 2,525 patients. 46% of those shown in green in the left Venn diagram had idiopathic pulmonary arterial hypertension, whereas the right side, the blue aspect, is 51% had associated pulmonary arterial hypertension. Of those, 50% or 25% of the overall population had a connective tissue disease associated pulmonary arterial hypertension, as shown on the right side of the Venn diagram. I also want to highlight there are other conditions that can be associated with pulmonary arterial hypertension that we will not be talking today. Those include HIV, drug toxins, and congenital heart defects. Our focus today, moving on, would largely be on systemic sclerosis. Here's a natural history slide of both diffuse cutaneous and limited cutaneous systemic sclerosis. I'm showing you the natural history as defined by University of Pittsburgh. What I want to highlight is that interstitial lung disease, which is also one of the leading causes of mortality in scleroderma, is an earlier complication of systemic sclerosis, whereas pulmonary arterial hypertension is usually a later complication. And I want to emphasize, usually, it doesn't mean that pulmonary arterial hypertension cannot occur earlier in the disease, but what we usually see is it's a later complication. And indeed, when you look at the causes of mortality in scleroderma from Pittsburgh database from 1970 to 2001, you see a striking change in the causes of mortality. In 1970s, the number one cause of mortality was scleroderma renal crisis. And in 1997 to 2001, the number one cause of mortality is pulmonary arterial hypertension and pulmonary fibrosis. So you can think about a combination of cardiopulmonary involvement. Why is that? We are screening more, we are diagnosing more, but unfortunately, we are delaying the diagnosis. Unfortunately, we are not aggressive in our treatment. We just published the data from University of Michigan on the survival over the past decade in our cohort, and pulmonary arterial hypertension and pulmonary fibrosis, unfortunately, continues to be the leading cause of mortality in our cohort. As I highlighted before, pulmonary hypertension is a hemodynamic observation. Once you make that hemodynamic observation, you as a rheumatologist, your colleague, a cardiologist, needs to make a classification, and there are 5 different clinical classifications of pulmonary hypertension. Pulmonary arterial hypertension, which we are interested in, and I've highlighted the connective tissue disease in red. But there are other mimickers such as PVOD, pulmonary venous occlusive disease, that can mimic pulmonary arterial hypertension, but the treatment is different. PAH therapies such as vasodilatory therapies can cause worsening of the disease with hypoxemia. When you think about a connective tissue disease patient, especially scleroderma or other rheumatoid arthritis and other diseases, they are older. They might have left heart disease due to diastolic dysfunction or myocardial involvement, pulmonary hypertension due to lung fibrosis, COPD, hypoxemia, pulmonary hypertension due to chronic thromboembolic. Therefore, it is paramount to work with an experienced pulmonary hypertension center colleagues to make this differential diagnosis because the treatment are very, very different. I want to now talk about the patient perspective in pulmonary arterial hypertension, and the focus would be on the left side, which is the pyramid I'm showing you. And as you think about pulmonary arterial hypertension, this is a review article that was published by Professor Magoon and colleagues that came from the World Symposium on Pulmonary Hypertension. The impact on overall quality of life, the impact on employment, education, the feeling of isolation, loneliness, exclusion, lack of understanding by others, frustration, depression, need for information, inability to perform activities that others take for granted. You go to the second part of the pyramid, concerns during diagnostic process, delay in diagnosis, multiple physicians and institutions before correct diagnosis is made, anxiety, fear, self-doubt, and the last part of the pyramid is to living with an incurable disease with chronic symptoms, oxygen therapy, decreased exercise capacity. Now, this is a perspective of a patient with pulmonary arterial hypertension. As we heard from our patient today, add scleroderma to it. I can make the same exact pyramid for a patient with scleroderma, combine both of them, and you can understand the anxiety, the fear, the depression, the impact on employment and quality of life. The right side talks about how we can partner in a multidisciplinary fashion to treat our patients, to provide them accurate diagnosis, aggressive treatment, but also psychological support, exercise, and rehabilitation. And we'll talk quite a bit about that in the future web series. Let's talk about the impact of pulmonary hypertension on quality of life. What I'm showing here is the data from SF36, which is a generic quality of life instrument that can compare domains across different diseases. SF36 had 8 domains from physical function, role physical, general health, vitality, role emotional, social functioning, bodily pain, and mental health. I'm showing you 4 representative populations: the normal population, the COPD, renal failure, and pulmonary arterial hypertension. When you look at the impact on the first 4 domains, the impact of COPD, renal failure, and pulmonary arterial hypertension is quite large and similar and very different than patients with general population. I want to highlight that higher score is better and lower score is worse. I also want you to pay attention on the last 4 domains out here, from role emotional to mental health. The impact of pulmonary arterial hypertension is very significant and much more than what you see with COPD and renal failure. This is an FDA workshop that was put together a few years ago, and FDA asked the patients with pulmonary arterial hypertension, what are the things that impact their quality of life? And they advocated the impact on participating in household activities, full-time work or inability to work, loss of independence, relationship with family and children, fear and embarrassment of having an attack in the public, fear of being alone. And this is really highlighted by Louis Goulevan and colleagues in an international survey. And here they surveyed 326 patients with pulmonary arterial hypertension and 129 caregivers. Look at the profound impact on employment in patients who have pulmonary arterial hypertension. 85% had a significant impact. And to me, equally profound is the impact on the caregivers. Because they're taking care of the patients with pulmonary arterial hypertension, 29% had an impact. 48%, or 1 in 2 patients with pulmonary arterial hypertension, are unable to work, and 13% of caregivers. And finally, 73% of the patients had an impact on their household income. Can you imagine having pulmonary arterial hypertension, the multiple therapies, the multiple specialities that you have to see, and taking care of your day-to-day activity and life? I want to end the first part of the series just to highlight the prevalence of pulmonary arterial hypertension and connective tissue disease, highlight the different classifications of pulmonary hypertension and how it is very important to distinguish the different classifications, and finally, the profound impact of pulmonary hypertension on quality of life, whether it's physical, mental, or social well-being. Thank you very much.